All right.
So before we get started, do we have any questions? What are we going to learn about this week? Neuromuscular, good. All right. So we got some people doing some previews. How much time do those previews take? 5 or 10 minutes? You doing it for other classes as well, or just this one? Because I said you should do it. Just this one? All right. Any other study habits that are clicking in with people that you like? Anybody change something that made it a lot better? Not yet. All right. Before we get on this topic, the neuromuscular topic that we'll be covering, I want to just briefly talk about how do we take care of ourselves? Anybody feeling the stress of the semester yet? Anybody starting to look at the calendar and say like, wow, we got exams coming up, we got projects, any papers coming up, presentations, anything else? How about the work-life balance? Is that starting to, everybody's got a lot of strength in the first week or two, but anybody starting to feel the drain of that? So before we get on our topic, I just want to talk broadly about how do we take care of ourselves, because I do think it's so important, and it's easy to say and really tough to do. So first off, if you're in a down spot, you feel like the world is coming down around you, you feel like you're stuck and you don't know where to turn to, there's one resource within CCRI that you could turn to. What is that? I said day one, if you learn nothing else but this, please remember this. Nobody remembered it. Okay, so if you remember any one thing about today, I want you to remember this next thing. My SSP, does that ring a bell now? No. Some say yes, some say no. My SSP, student support services, something along those lines. It's a way that you can reach out 24 hours a day. Some sort of emotional mental health counselor will contact you and be able to talk to you 24 hours a day. So if you feel like you really need some help, those are some people you can talk to. Academically, reach out to me. I can help and steer you in any direction that I can possibly think of to help you. What are some other ways we are supposed to be taking care of ourselves? What are some good, healthy habits that we should to manage life and stress? What are some other habits? Sleep well. Whose time to study? And I know this is the time I have to work. I get my work done when my kids go to bed. When my kids and then my wife go to bed. I have to wait until my wife goes to bed to start doing work, right? So, yeah, I start my work at 8:30 at night. How about you guys? I'm seeing a lot of head nods, like, yeah, that's it. Like, there's no the time for me to start learning is at night already. All right, so that makes things really hard. So sleeping well, having good sleep habits is really important. Getting to sleep early, similar times every single night, making sure your sleep environment is good. Less light is better for sleep than more light. There's some research that says blue lights are worse than any other kind for restful sleep. So you can change your environment slightly, but I think the dedicating enough time to sleep. And it's really tough because my kids wake up at 6:30 a.m. There's no snooze button, right? So it's really tough when the only time I have to myself to study and to work starts at 8:30, and my alarm clock named Nash and Scarlet go off at the same time every day, and there's no way to avoid it, right? So finding ways to make sure that you are being consistent with your sleep, making sure you're staying on top of your studying so you don't have to study 3 hours in a night, that you can get by with just 1 hour, right? That's easy to say, tough to do, but it's something to consider. What are some other healthy habits that are good stress relieving? Good diet, absolutely. Good diet. And it's, again, really tough because when we're studying, when we're busy, what's easy to eat? Snacks, easy. Anything else? Fast food, pre-made food, right? Any of that is easy to eat. If you go into, where do people like to study? There's no food allowed in libraries. Anybody like to study in a library? I don't understand you people. I need a busy environment. That's how if it's too quiet, I go nuts. I got to start making noise. Yeah, I like that. I like coffee shops. I like busy, quiet coffee shops. No, I gotta go. I like a busy, active coffee shop. But what kind of foods, what kind of nutrition is in those coffee shops? Caffeine, definitely. Cookies, muffins, yeah, nothing of quality, right? So keeping track of your diet, making sure that you are intaking good food as well. Any other ways? How about exercise? Yep. Having good exercise. And I mean, what are we going to be encouraging all of our patients to do in the future? Exercise, staying active. And even at the conclusion of our course of physical therapy, we're going to say, you should really continue to exercise. It's the best thing you can do for your life is to continue to exercise. But as students and as busy professors, what's the first thing we eliminate from our daily routine? Exercise, right? How backwards is that? So keeping, dedicating yourself to maintaining some level of exercise, at least a fundamental level of 30-ish minutes a day, most days of the week, would be the foundation. More is always good, but that's up to you to determine. I've had students that say, if I can think of one in particular. She works out 2 hours a day and has throughout the entire time I had her as a student. I tried to hire her to work for me as a PTA, and 2 hours a day. She rearranges her work schedule. So in the middle of her day, she has 2 hours. She works early and after, and then she tackles her kids at the end of the day. That's her dedication. She feels like less than that, she can't function in the world. Okay, great. That's good for her. She knows it, and she's going to hold herself accountable to that. I think that's something that we should hold ourselves accountable to, some level of exercise. Now, give me some broad ways to exercise. Chasing toddlers, does that count as exercise? It's exhausting. I don't know if it counts as exercise for us, right? What are other ways? Walking, taking a walk. Any other ways? Jogging, riding a bike. Going and lifting, going and playing a sport, playing soccer for 2 hours, right? Or even an hour, right? Those all count. Now, what I like about jogging, cycling, walking, can we study at the same time? I think there are ways we can. When we last week talked about active studying versus passive studying, we have to lean towards more the passive studying part, right? Listening to a lecture, watching a video as we walk on the treadmill. It's tough to be truly active and creative to do it, but there's ways we can double dip. A little tough to study flashcards getting put in a Kimura, but there's other activities we can do. The other kind of big topic, and this is hard to do too, is taking time for yourself, putting away the books, putting the books to the shelf and saying, I know I will be okay if I don't study today. And that can be really important. Get together with friends. That's one of the other reasons why study groups are really good. Study groups are good because hopefully you study. How many people have been in a study group where you got off track and you just laughed and chit chat and you got off course, but it was a fun day? But that still counts as something good for your life. So another reason why study groups can be really good, because they are a stress reliever as well as an academic purpose. But even just getting together with friends, going to a movie, watching a funny movie, laughing is a stress reliever. So finding something funny, something that entertains you can be important too. So what I'm hoping you can do, and we've got an exam next week, so it's a good time to start to really try to balance your life, is take a personal inventory. Am I doing the things that I'm supposed to be doing to take care of myself? Because there's only so much gas tank we have. You know, we've only got so many gallons in it, and if we start burning it down, what's going to happen at finals? How many people have limped to the finish line in finals, where you're supposed to be at your best, show how much knowledge, and you barely got through that final exam? You had an A in a course, and then that final exam, you just said, I can't do it anymore. I've been there. Is it that final week that did it to you? I think it's the cumulative effects of the previous 15 weeks that led up to that not being your best at the end. How many sports fans do we have in here? Basketball fan. How about it's load management, right? Isn't that what we're talking about? Load management. Same thing as making sure we don't give Jason Tatum too many minutes throughout the year. If Porzingis can play at all throughout the year, who knows? So it's the same kind of concept. Managing your load, managing your stress all of the time, not just at that final piece. So, all right, let's talk about neuromuscular stuff now. So we have, where's this thing? Our objectives. So what is the anatomy and function of the neuromuscular system? So how many people have already taken anatomy? Just a quick show of hands, handful. And I think at least probably 50%. Show me a quick show of hands who's in anatomy right now. All right, so close to half. So this is a slight preview on your anatomy. What I hope that we are also going to do throughout our time together is just show you the importance of your anatomy knowledge. I think for anatomy, most of you are going to do really well for the bones, muscles, ligaments. That tends to make sense for us. What can be more difficult is the integumentary system, the nervous system, the cardiovascular system, but every single system makes a big impact with us in physical therapy, and we can treat some problems with every single system. So the neuromuscular system, central nervous system, and peripheral nervous system. Central nervous system includes the brain and spinal cord. The function of the brain and spinal cord is data processing. I should say the brain, the spinal cord is really just a transmitter of signals, but the function of the brain, data processing and decision making. The peripheral nervous system, spinal nerves, peripheral nerves, cranial nerves. And all this job is to send signals. That's all it does. It sends signals up to the brain, and then it sends signals down from the brain. That's all it is. It's a telephone wire, if we had telephone wires anymore. What a dated reference that was. So I'm going to expand on this a little bit. Nerves send signals to the brain. Brain processes the information and then makes a decision on what to do, and it sends signals to back down the nerves onto something that should happen. All right, let's put this in real life. If I'm walking along and I step on a nail, nail goes through my shoe and right into my foot. What happens next? Feel pain. Exactly. So before we even feel pain, what has to happen is the body has to sense that signal. That signal is pain. That signal is danger. There's a bunch of different signals that we could have. Light touch, if you guys had a light touch versus deep touch versus pressure, there's a whole bunch of them. We're just not going to get into now, but there's a whole bunch. So receptors are going to feel that damage, and they're going to send that signal up my nerves. So if I stepped on that nail, it's got to go from my foot, up my leg, into my back, up a spinal cord and into my brain. The brain then has to figure out, okay, the right foot is telling me something is damaging this foot. Does the body want damage? No, no. So the body says, okay, do something about it. What's it going to tell my body? The brain has processed it and said, okay, we don't like this. What is the decision that the brain is going to make, and then send a signal back down to do what? It will eventually repair, but we're not even repair yet. We're still stepping on a nail. Get it off. Get your foot off, right? That might look like me picking up my foot a lot. That might make me look like I'm going to fall down to the ground to then try to figure out what's happening, right? I don't know exactly what it's going to look like, but it's going to say, there's a problem here. Get off the problem. Does that make sense to everybody? All right, so sensation to nerve to brain, figure it out, back down to tell the muscles to contract somehow. That's how the messaging works. All right, let's make things more complicated. If I'm a high-rise steel worker building a new tower in Providence, if I step on the nail as I'm walking on one of those I-beams, what's then going to happen? Still feel that damage, but I'm 12 stories up on a narrow beam. Brain's going to process damage. What else is going to, what's new factors is it going to also? It's going to say, I don't want to fall either, right? What would the body rather have, a hurt foot or a fall? Hurt foot. So now the body's going to say, send a much different signal and have a much different reaction based on the other data, right? Does that make sense to everybody now? So that is what I mean by the brain being the data processing and decision making. Do the nerves have any input on what to do? No, they're just sending the signals up and down. They're just telling what to work and when. So what's fascinating to me is the different areas of the brain. Now, you will learn this when you take your anatomy class. You're not there yet. You guys who have already taken anatomy, is this more anatomy 1 or anatomy 2 information, the different lobes of the brain? Do you remember? 1. So different lobes of the brain have responsibility for different functions. The frontal lobe in the front here, personality, judgment. How come we can tell jokes with our friends at a bar that we would never tell on campus here and in this classroom? Because the context of what we're doing and who we're around would tell our brain, our frontal lobe would say, you really shouldn't do that. That's a joke for later. Type that joke. Don't say it out loud, right? You know what's really fun? To work with people with brain injuries to the frontal lobe, because they have none of that filter. Different than if we had a patient with a parietal lobe problem, which has a lot more spatial and visual perception, some sensory touch. So a person with a frontal lobe problem will not look both ways before they cross the street. A person with spatial perception problems, the parietal lobe, will look both ways, but not be able to judge, is that car far enough away for me to cross the street, or do I have to, like, they know they have to be safe, but they won't be able to judge how fast is that car moving, can I cross the street the right way? So different areas of the brain, depending on the injury to it, and we'll talk about a couple different injuries broadly, will greatly impact the differences in symptoms that our patients come to us with. And that's one of the most fascinating things about the neuromuscular system is when you start talking about different brain injuries, the variety of symptoms that can come from it are really wide. One ankle sprain is going to look exactly like the next 10,000 ankle sprains you see. A little bit more swelling here, a little bit less there. They're all the same. The brain, once we get into brain injuries, the variety of symptoms are really remarkable because of the different functions of the brain. So some injuries that we're going to cover, different injuries to the brain. TBI, what's that? I think we've used that. Traumatic brain injury. I think we've used that before in this class, right? Does anybody remember? CVA. Isn't that what that one is? Accident. Yeah. Cerebrovascular accident. PD. I don't know if we've used that one yet. That one's Parkinson's disease. Muhammad Ali, Michael J. Fox. SCI, spinal cord injuries. I think we've used that one a couple of times. Peripheral nerves, physical injuries are the most common to the individual nerve itself, but multiple sclerosis and ALS are others that affect the physical makeup of those nerves. I think one of the more common, I'm blanking on who it was. One of the more common peripheral nerve injuries, right on the outside of your knee, right below the knee, there's a bone there, the fibular head, for if you've already taken anatomy. There's a nerve that runs right next to that. That is a really common peripheral nerve injury, especially from soccer and football tackles. We got a big collision right there, creates the nerve problem. There was some football player that had that and had to try to return to NFL wearing a foot brace because they had that nerve injury. Does that ring a bell to anybody else? I thought he played for the Cowboys, and this is a handful of years ago. This isn't, last year. Anyway. So those are some of the types of injuries that we might be, injuries and diseases. These are some also diseases. I should have put that. So mechanisms of injury or illness. Physical injuries are easy to think of. Traumatic brain injuries, spinal cord injuries, peripheral nerve injuries. Those are easy to think of. Different disease processes, ALS and multiple sclerosis. We could have genetic disorders, cerebral palsy, good example of that. And idiopathic, that's a fun word. Anybody know what idiopathic means?
Idio is like knowing, not knowing.
Yeah. Way to break down the word. That's good. Did you learn that from MedTerm, how to break down? Yeah. Yeah. I don't know. Fancy way to say, I don't know. Why do we get vertigo? I don't know. Oh, you mean it? No. We are in the medical world. We don't say, I don't know. We call it idiopathic because we don't want our patients to know we don't know, right? So we say, hey, it's idiopathic. I should say we don't know yet. That's probably a better way to be kind to our medical world. But yeah, we don't know. Anybody have vertigo? Vertigo is a problem with somewhere along the way, the inner ear sensory signals to the brain. The inner ear has 3 canals, like they look like half a hula hoops kind of, and they're all oriented different directions. And there's fluid and sensory signals in there that help determine where our head is in space. Yeah. I got kicked out of the other room because someone else bumped me. This is quite the chain of events from happening, huh? Would you be able to use that room, or would you have to be in here? Are you teaching French? Because there's a lot of French posters in here. All right, we do not want to ruin an exam night. So we will move. I don't want to create more stress for the people taking exams. We will definitely move, okay? I know it. I know it. I don't want to do that. So we will. Is that room next door open again? Because we'll kick that guy out. You and me tag team that guy. I'm gonna pause my recording here because I have some. All right. So vertigo, I'm sorry, idiopathic means we don't know why it happens. Sometimes it just does. So we always talk about what do we measure? There's always things we're going to measure. Why do we measure it? Number one, safety. Are we able to participate in today's treatment? Potentially, can the patient return to home? That's part of our safety decisions. Can they return to driving? Right? Can they return to sport? All of these things are important safety measures. Are we making progress? Based on this measurement, we are making progress, or no, we're not. And I got to tell you, for some of our neuromuscular conditions, that for the family is going to be really important information. Way different than just any old, muscular injury. And then decisions on today's treatment. So we'll look at how that impacts us. But 3 major things we're going to measure. Now, I hope you understand that when I pull the major things I'd like to talk about for measuring, we're going to measure everything the patient needs us to measure. It's not just these things. Oh, you had a traumatic brain injury. Don't worry, I know 3 things to measure. No, we're going to measure everything the patient presents that we might need to measure. I simplify things for our class because you can't learn everything, especially in an introductory level class. And when we're just moving classroom to classroom, we burn a lot of time, can't learn everything. So the 3 things: sensory integrity, cognitive integrity, and then we'll talk about our gait or walking ability. I should make that a little bit more broad. We'll talk about that in a second too. So sensory testing, altered sensations are common with different neuromuscular disorders. Example I think we've all had. Anybody driving, anybody rest their elbow on the either windowsill or the center console and their hand goes numb, right? That's a peripheral nerve injury. It's a compression injury of your ulnar nerve, which causes paresthesias, the altered sensation. Now, luckily, the injury, what's the treatment for that? Move your arm, get the pressure off, and then how much time does it take to resolve? Minutes. Anybody have it linger for like an hour? Sometimes that happens, especially if you literally fall asleep on your arm. Like if you fall asleep in your arm in a weird position, you wake up and then been in there for an hour or 2, then that can happen. So, but yeah, resolves quickly. So everybody here has had a peripheral nerve injury. It's just it resolved within minutes. But what's the sensation of our hand after we do that? Needles. Yep, that's the feeling in our hands. How about, like, does anybody ever do it so bad where they can't like button a button or can't operate a pencil or grip something hard, right? So that is the type of thing. Then how about I can't feel my hand, like I'm hitting my hand, I can't feel it, right? So that's a sensory problem of the neuromuscular injury. Where the neuromuscular injuries can be crazy is that origin of the injury could be the peripheral nerve, like we're using our example of resting our arm, or it could be in the brain. So testing can include, I was supposed to bring some things here. Anybody with your backpack, keys, pens, any coins, any coins or paper clips or hair clips, anything that is a common object. Anybody have a coin on them? Coins are the best ones to do it. I was supposed to grab this stuff. So my dated references for tonight are telephone wires and physical money. You got a coin? Perfect. All right. I'm going to give this back to you. Who wants to be my patient? All right. So this is the stereognosis test. Now I already gave away some of the answers. She already knows what I'm holding in my hand. But for our patient, we would have a selection of items to choose from that they would be unaware of. We'd ask our patient, please shut your eyes, hold out your hand. Good. I'm going to place an object in your hand. I need you to tell me what it is. A coin. Great. Keep your eyes closed. Tell me what coin. A quarter. Okay. Then I need you to tell me which side is heads and which side is tails.
This is tails, and this is heads.
Good. Are we right? Let's keep your eyes closed. Keep your eyes closed. Good. Next two questions. What year was it minted and which location was it minted? All right. I don't think we're going to get there. Thank you. You're good. You're good. So that's a stereognosis test. Obviously, our patient should not know that this would be a quarter first, right? We would just say, shut your eyes. I'm going to put a common object in your hand. That common object might be a key. It might be a paper clip. It might be coins. But the identification of what is this common object in your hand? Because what did we ask the patient to do other than identify? What did we ask their nervous system to do? Feel. Focus, absolutely. Some memory, data processing and decision making, right? So when we went back earlier and we talked about if I step on the nail, sensory, nervous system, the nerves send the signal up, data processing, and then decision making, right? So the decision making, we don't have a physical decision making. I guess some of the physical decision making is, okay, flip the coin over, feel the other side. Which one should it be, right? So there is some. But yeah, that's a whole lot of nervous system testing for just tell me what's in your hand. Isn't that cool? No, you guys, some of you think it's cool, some of it's not. I didn't think any of this stuff was cool when I was in school either. I find it fascinating now. Graphesthesia. Identifying writing on a hand. Letters, numbers, common shapes are typically used. So here's what we do, and I want to take a moment and you can play this with someone else. Can I borrow your hand? All right. So your wrist is going to be the bottom of the paper. Right. That's really important for both of us to understand, because what we're going to ask you to do, go ahead and shut your eyes. I'm going to write a letter on your hand. I want you to tell me what that letter is. Okay?
Okay.
Hey, good. Keep them shut. I'm going to draw another letter. Let's do.
Okay.
Perfect. Great. You can open them up. So that's the graphesthesia test. Who took med terms that want to break that down for me? That word. Isn't graph right? I think that was one of the words on the French posters, isn't it? What's French for to write? I don't know. No. I only speak a little bit of French. Oh, oui, oui. That's about it. All right, so let's do this with someone else. One person be the therapist, one person be the patient, and then you guys switch roles. Patient's going to shut their eyes and hold out their hand. Make sure you know what the bottom of the paper is, because if I draw a 6 and they say 9, okay, well, is that an orientation problem, or do they not? Is there a cognition problem, right? So make sure we understand what the bottom of the paper hand would be. Common letters, common numbers, and single numbers. Don't write like pi 3.1415, or simple shapes. Okay, try that out real quick. What that character was pretty easy for the most part. It's really fascinating when somebody can't do that. We could also do a hot versus cold test. So I don't want to get too crazy into it. But there are some conditions, spinal cord injuries and different brain injuries, that would render someone unable to identify hot versus cold. So you guys know what a reflex hammer looks like: metal and then a little rubber on the end. you could use test tubes with water eat too, but the way I typically do it is I have one object, pen or that metal piece of the reflex hammer. I put it in an ice pack, and I put another one in a hot pack. So one of them's hot, one of them's cold. And then I go with the patient, okay, shut your eyes. Tell me if this is hot or this is cold. And I put one of them on. They're supposed to tell me hot or cold. And I mix up I don't alternate hot versus cold. I don't want them falling into a pattern. They're supposed to like get the right answer. So I'm going to randomly do it. There's actually a girl in Narragansett. I don't know if anybody read this in the newspaper. She has a extremely rare genetic condition. There's only 3 people in the world with it, where she cannot feel pain and she cannot determine hot versus cold. Did you read that article? Yeah. So really, really fascinating. That's a genetic condition. So anyway, kinesthetic awareness, the easiest test for this, there's a bunch of them, but a mirror test. So there's a couple different ways to do this one. What we would then do, can I borrow you? All right, so just sit there. Good. I'm going to move this arm. Your job is to mirror it with this one. So good. Good. Come on, man. I thought we were. All right, so someone who has spatial problems, one arm is going to be like this, the other one's going to be like this, because they can't feel that sensation. Oh, my arm's here, my arm's here, right? They're going to be off somehow. So another interesting thing for that. Any questions on sensory testing? A few different ways we can do it. Now, cognition testing can be a lot more complicated. It can be kind of simple, but it can be really complicated. Now, they can be common when and likely expected with injuries and diseases that impact the brain. What I will tell you beforehand is it will greatly impact how we provide physical therapy for someone, but we aren't going to be the people treating that. That's going to be outside of our scope of practice for both physical therapists and physical therapist assistants. But we can measure, we can still measure. And why do you think we would measure cognition? Why do you think, what ways would it present challenges to us in physical therapy? We're just going to get them up and walking and doing squats. Can they go home or not? Yeah, it's give us a safety measure. No, this person cannot go home because based on this cognition score. That's when my grandfather, when he was still alive, that's when he stopped being able to live independently, is when he couldn't figure out what would he do. He would do with the microwave. He wanted to microwave something for 2 minutes, so he'd put it on 120 minutes, thinking it was 120 seconds. It was like little things like that where you go like, okay. And that's multiple attempts at learning in a row. This isn't a new microwave. Like the cognition is starting to decline, and now it's a safety problem, right? So he was 96 at the time. Lived alone a long, long time. Anyway, so safety, can they go home or not? Yes. And it's a lot better from a family to not have it come from our judgment. Nobody wants to hear, I don't think they should go home, because now who's the enemy? Us, right? But if we say, based on this test, we are having problems with cognition, we have big safety concerns. That's a much better conversation. Any other reasons? I think I have a couple of examples later on that will highlight this, but impairments might include levels of consciousness. I've had plenty of patients fall asleep on me. I've had more students fall asleep on me somehow, but plenty of patients have fallen asleep on me. And not because what I'm doing I mean, I'm asking them to move. Anybody fall asleep while there's somebody's asking them to move and exercise? Like, it's really tough. It's their level of consciousness. Their brain is saying you need to shut down and rest now. Orientation. Who am I? Where am I? Who are you? What are you doing here? Memory, both short and long term. Short term is typically the first memory to go. Long term memories are typically preserved. That's a good little trick if you're talking with someone who's a loved one or a patient. If you do notice that memory, I've had plenty of patients know they're having trouble with their memory and get really frustrated to the point where it's impacting our extra. We can't complete physical therapy because they're just so frustrated with themselves. I start tapping into their long-term memory to break them out of that. Tell me about your first car. Tell me about, you said you and your wife were married for 58 years. What was your first date like? Right, tapping into that long-term memory typically remains intact for much longer. Reasoning and judgment. Talked about that with the frontal lobe a little bit, right? So those are all different levels of cognition, different impairments. So some methods to do it. The 3-word recall test, repeat 3 words, red dog house. I'm going to teach you 3 words. Those words are red dog house. What are those words? And they should be able to repeat that right away. I'm then going to do another task. And I'm going to come back at the conclusion of that other task. So about a 3 to 5 minute gap. Hey, remember those 3 words? What were they? I can then perform 1-step to 3-step commands, starting with 1-step commands and then building the number of steps that those commands would be. So raise your right hand. Everybody raise their right hand. Good, go back. Raise your right hand, then stick out your tongue. Don't. Right, so now we do it. Raise your right hand, then stick out your tongue. Right, that's a 2-step command. Raise your right hand, stick out your tongue, then clap. Right, so some of our patients will be able to do 1, maybe 2-step commands, but when we get to 3, 4, and 5-step commands, they're going to start getting lost. Now, a couple of ways that this can impact us. One, the memory test, the repeated 3-word test, if someone's failing at that, do you think they're going to remember to do the home exercise program that you showed them? What if you printed out them a picture? Do you think they're going to look at that picture and know exactly what you're going to, right? So your compliance for home exercise program is now greatly impacted because of their levels of cognition. Anybody ever try to teach someone either a new exercise or a new like sports skill? Or riding a bike, right? How many steps is it to break down hitting a heel lock? A lot. Yeah. How about, what are some other tasks we've taught someone? He and I speak jujitsu together. So what are some other tasks that you guys have taught? Any exercise? Who's personal trainer in here? Right. So what's giving an exercise that's
complex?
Yeah, right. So like a clean is a lot harder than a deadlift, right? So yeah, the multi-step process is way harder. Riding a bike, that's really tough. Riding a bike without training wheels, really tough. So I tell you what, when I teach Tanner, Chad, sorry, Chad, he sits next to Tanner. I always get them confused. When we teach I just taught these first year PTA students, how do we teach someone how to roll over in bed when they can't? There's 7 steps to do that safely. That's really tough to teach someone who can't remember 3 words. And can't remember 3-step commands. We've got to really break everything down to 1 and 2-step commands. It can be really tough. There's also various questionnaires. Let's see if this link works. Open it. So this is a nice questionnaire because again, it's not my interpretation of something. It's just it's a piece of paper. We're going to take a little test. We ask the patient what's the exact date. We ask them to draw a clock with a specific time on it, 10 minutes past 11 o'clock. So now we have some spatial perceptions we're testing here. We have that recall. Can you tell me something that happened in the news recently? That can be a tough one for some people. What was the name and address I asked you to remember? So you can kind of keep looking at that. And at the end of it, we just get a score. A score out of 9 for the patient information, score out of 6 for the informant interview. So it's total score of 15. 0 to 3, cognitive impairment is indicated. 4 to 6, no cognition impairment. So that just gives us a test that it's not me guessing if the patient has some sort of cognition problem. So there's a bunch of different versions. I shouldn't say versions of that, but different options we have for it. But that was an easy one to give a demonstration to. So the next thing is mobility testing. So that's how I should call it. We're going to focus on walking, and it's called gait. There's a lot of different ways to measure gait, but broadly, does everybody walk? No, right? So we should be calling it mobility testing because I can test someone's ability to have locomotion with wheelchairs, power scooters. Let's see, this week I've had people who walk, who use a power scooter, who use a wheelchair. Power scooter, she's independent with it. Wheelchair, he's dependent in it. I had one person who had a really specific neuromuscular condition where he couldn't walk, but he could use a Segway scooter. So that's his means of locomotion was Segway scooter. That's how he found his best mobility. So I'm just going to focus it on gait for today, but there's a lot of other things we might have to measure. So identifying gait deviations. I think I have a video of this later. All right, I do. So gait deviations, anybody ever stub their toe at? You ever step on a Matchbox car or a Lego? I've stepped on plenty of Legos. All right, so what happens? What does our gait look like immediately after? Hopping on one foot, right? So that gait deviation, let's see if we can get this. So you're walking along, then you, right? Then you go, son of a, what? Who put that? Put your toys away, right? Right? What's that? Does that look familiar to anybody? Right? So that's called an antalgic gait deviation. Now I won't have that. That's not on the test. I'm just telling you an example. And it's similar to an ankle sprain, right? You put your foot down, can't quite do it, right? It might not be that pronounced, but it's there, right? There are other gait deviations. Can anybody think of other gait? That's probably the most common one for us. Any other gait deviations we can think of? Ways we move that's not the perfect, heel toe, good stride, good step length. Skipping. I wouldn't call that a gait deviation unless they couldn't walk. If they had to, there are shuffling gaits, so there might be this kind of a gait. Yeah, that would be a gait deviation. If we did it fast, it might be a shuffle. Yeah. Feet either toeing in or toeing out, gait deviations. Yep. Toe walkers. Yep. Happens more in kids. Yep. That's a neuromuscular condition. That's mostly because of sensory problem rather than any other mechanical thing. But yeah, that's a great example. And have you ever seen anybody have to swing their leg way out wide? Anybody have to wear a knee brace for a while that couldn't bend their leg right? How did we walk? You had to swing that leg around, right? We call that a circumduction gait pattern. So what are the gait deviations? Now, gait deviations are a problem because they take more energy to walk. It takes more energy to walk like this than if I were just to have my normal walking, right? So when we consider walking distances, we learned seashells here. That we got our class moved because of seashells by the seashore. My goodness. What was I talking about? Gait deviations cost more energy. So when my older adults already can't walk the parking lot to the CVS without getting winded, do we want to add a gait deviation that costs more energy to get them from A to B? No, right? So we lose efficiency with walking. We can measure the distance to ambulate. That's my favorite thing. Let's walk as far as you can for the right people. Would that test work for anybody here? Well, let's walk as far as we can. We'll just, whenever you're done, we'll just stop. We'd be walking to Westerly. Actually, as long as we have adipose and muscle tissue, we could walk, tremendous distance, halfway across the country until we need calories to stop us. But I tell you what, for plenty of my patients, especially if they have gait deviations and the energy expenditure is a lot higher, they can only walk a few hundred feet, maybe even less. I've had plenty of patients that can't walk 10 feet without a rest. So some patients, the distance is good. Gait speed is my favorite thing to measure. In order to be considered a community ambulator, that's crossing a crosswalk with a lot of effort. 0.6 meters per second is the minimum bar. 1.0 meters per second to be considered a community ambulator. And in the home care world, I get insurance companies saying, why are you still in there? We need to discharge this patient to outpatient. My number one answer is their gait speed is 0.5 meters per second. They need to be a 0.6 to be a limited community ambulator. We're not there yet. This person doesn't have someone to help them, and it's a long parking, where they're at is a long parking lot. They need to be at 1.0 meters per second before they can walk out of the house safely. That's how I use this, right? So again, what is the measurement? How do we use it? Measurement gait speed, using it for safety. Can they get integrated into the world or not? Or do we still need physical therapy? There are other gait tests we can look at. Here's the Tinetti balance scale. I love this one. I use this one for every single patient I work with. I do it. That's a little bit too much. 99% of the patients I work with, I use the Tinetti. So it's really nice. I watch them walk. I give them a little score if they, how do I zoom this in? A little bit better. If I say, okay, patient, go, if they hesitate, I give them a 0. If they go right away, I give them a little 1. I look at their step length. Do they step through their other side, or do they have that shuffle kind of gait where they're stepping to their other foot? I score them appropriately. Do they clear the foot or the floor, or do they always maintain contact? Do they look equal? Are they continuous, or are we stopping? Anybody ever see someone with a walker that walker, step, step, walker, step, step? All right, that's a discontinuous gait pattern. Anybody ever see someone, maybe a loved one, that in order to get around this, they're going to walk and then they have to stop and collect themselves and kind of get, okay, now I can walk. Anybody see that? Right. So that's a discontinuous gait pattern. Path. Do we walk straight, or are we really all over the map? Who's ever been out on maybe a birthday of a friend and tried walking to the Uber? It's 30 feet straight line, but somehow this watch says we went, right? So that's path deviation. Now, what I also like about this is if we're using some sort of assistive device, AD is the abbreviation for assistive device, I think we'll look at later. Walkers, canes, anything else that might, walking sticks, those we would downgrade that person if they're using that. So even if they're perfect but using a cane, we're only going to give them a maximum score of 1 there. And you don't have to know that for now. But what is, and then I do some balance tests with this as well. Can you sit and stand? How many attempts does it take? How many you ever see someone, older adult, where they have to rock a bunch before they actually get up? And how about if they get I didn't quite make it, but the next time I will. Yeah. All right. So that's multiple attempts. So again, I mean, all I'm asking the patient to do is, can you stand up for me? And then I just score them how well they did it. Eyes closed, nudge tests. Those are fun. Turn around 360. At the end of this, I get a score out of 28. 24 points or more, low risk of falls. 19 to 23, moderate risk. 18 points or less, high risk of falls. So again, it's just, we're measuring something that's a little abstract. Risk of falls. How can we measure risk of fall? I mean, we all know it when we see it, right? But can we just write? Can we measure progress if it's going by our gut saying, I think you're at risk of fall? No. Can we make decisions based off of it? Can this person return home or not based on our gut feeling of, I think they're going to fall? No, we can't do that. All right. So we're getting a number for something that can be hard to measure, like a risk of fall. So I love this Tenetti. And it's really fast. When you're good at it, it takes 10 minutes or less. Any questions on those tests that we did, sensory, cognition, or gait tests? Yep.
The last gait test, would that only be used in like a in-person or an inpatient facility where they need to get out to go home, or would you use that like where they just come in on instruments?
We can use it in outpatient clinics as well. If you, High Bar, right in Charleston, that's where you're working? Richmond, right. I guarantee you, if you ask your clinicians there, have you ever used a Tenetti in here? They're going to say, yeah, we have. It's not often. Because typically, if they're already getting to an outpatient place, they have mobility anyway. There are other ways to measure balance. Berg is a better one for that kind of a person. If my patient's a gymnast, how are they going to do on that Tenetti? If my patient is a gymnast with a severe ankle sprain, how are they going to do on that Tenetti? They're going to look pretty darn good, right? Even with a bum leg. So I have to select the right test for the right patient. So it's all patient driven. And that's the skill of the physical therapist, to tell you the truth, is knowing which test to use. All right. So here's a couple of concepts for treatment of neuromuscular condition. First step is recovery versus compensation. Will these impairments be temporary or will they be lifelong? We don't always know the answer. Not every stroke is going to have lifelong impairments. Some are going to resolve completely. Some are going to have minor problems. I have a friend, she had a stroke at the age of 22. Really rare. She has no residual symptoms except her left side of her face droops when she's tired. At the end of a work day, if she doesn't get a good night's sleep, that's the stroke impairment is showing through. Happy energy first thing in the morning, as long as she got a good night's sleep, you would never know it. Exercises all the time, no problem. When she gets tired, she plays 2 soccer games in a row. That second soccer game. Sub, why you sub me out? Face is drooping. Get out of there. Take a water break, right? So that is part of our decision making, because we need to know, are we going to improve upon this, or are we going to create a compensation? So that gait deviations I talk about, if the patient is going to improve, we want to get rid of those gait deviations. If they're not going to improve, if these are going to be lifelong impairments because of their neuromuscular injury, we're going to solicit, we're going to ask, we're going to give them more compensations. To be able to ambulate, you're just going to have to do it this way. So there's a neuroplasticity is the name of this next concept. That's the ability for brain and spinal cord to adapt and create new pathways to send its signals. A non-neuromuscular injury. Anybody ever tried to learn how to dribble with their non-dominant hand? Do you ever hear about putting your arm in a sling and just doing everything with your left hand for a couple weeks? Right? Yeah. So all we're doing was we're restricting the one thing and forcing you to use the others to train the brain how to operate this other hand. Now, neuroplasticity, let's go back to this picture here. Broadly speaking, and my friends who are better neuromuscular PTs would laugh at me with this very simplified definition. But here's what would happen. If we have an injury to this area here, the brain can say, okay, well, these tissues aren't going to send signals and make decisions anymore. They're not going to process that data. But if we keep trying, we're going to create new pathways around that injured part. So we can get functional recovery. We can learn to walk again. We can learn to dribble with our other hand, right? So that's what the neuroplasticity is. You have this problem. This problem's not going to work. But we'll just have to create new pathways around it, and you'll be able to walk again. It's just going to take a while. Learning how to walk again, creating those new pathways. All right, that's the broad example of what neuroplasticity is. So when I talk about these different conditions and ways we could treat it, are we treating it to recover and create new pathways, or is this not going well and this impairment's going to last a while and then we have to compensate around it? So if we're trying to treat sensory impairments and we think we can recover, we can do stimulus retraining. So that's in the stereognosis example. Maybe we start with larger, simple objects and work our way to smaller, more complicated objects. That would be the way to treat it. Anybody ever get so like they're sick, they get the flu, and the sheets and blankets touching their skin is irritating, right? So that is your nervous system firing. That's a sensory problem. Anybody ever have it last? Anybody ever have a surgery where the incision just is so hypersensitive for such a long time that it takes a while to get used to it? So that can happen. There's a bunch of other conditions that might happen, but a lot of times the incisions are so sensitive that patients have trouble with touch. It's so hyperactive, hypersensitive. So what we would do for that person, we would do stimulus retraining. We'd start with the softest objects possible, the most tolerated, and work our way to rougher, more abrasive. So starting with silk and working our way to denim to wear pants, right? So that's what the sensory retraining could be. Compensation. Listen, this sensory impairment's not changing. We've been at this for a while, and we are not creating these new pathways. This is going to linger for a while. If my patient has trouble with sensation, I need to start educating them. If you have lacking sensation of your feet and legs, you need to do foot screens to make sure you don't have a wound. Because what happens with foot wounds? A cut in your bottom of your foot. It's going to get infected, right? So we need to do skin screens. How many people here think like, oh, let me check the bottom of my foot for nicks and cuts? Doesn't happen, right? For someone who has sensory impairments, we have to start teaching them that stuff. Another thing would be to avoid space heaters. Anybody ever know anybody who has a space heater and they put it? Well, here's what happens with a space heater. If you're the kind of person that needs a space heater, where do you put it? Right next to you. Right. I can't tell you how many patients have a space heater that they are an inch away from that space heater. If we have altered sensations, what's going to happen with that patient? They're going to get a burn. They're going to get a burn, right? So the recovery would be to add stimulus and progress as we can. Depends on what the stimulus that we need to. Compensation is to educate. For cognition, most of this is likely provided by other members of the healthcare team. Occupational therapists and speech language pathologists are the two fields that will mostly handle recovery of cognition. What it looks like is, you guys ever see like a third grade homework book? Here's how many apples Bobby has. Here's how many apples Susie has. How many apples together do they have? Right. So that kind of, you guys know what I'm talking about? Or is that another dated reference for me? Or how about like brain games? I know with our phones, there's a bunch of brain games that you could play. Anybody have any that, so that's what a lot of it looks like. To an untrained person like me, that's what it looks like. I'm sure there's way more involved in selection of what to do, just like there's way more involved in rolling over in bed for us or walking for us. It's way more complicated than just walking. But that's what it looks like from an uneducated perspective. Compensation, again, safety education, but mostly if they have cognitive impairments, it's looking at family support and telling the family how to look out for that person. So even though we won't be directly addressing the cognitive deficits, it will greatly impact PT treatments. How do we communicate with our patients? What is their ability to learn? How complex is the task? What are some, when we talk about getting back to function and prior level of function, what are some examples of prior level of function? You think for some people with cognition, we're talking brain injuries, either with strokes or traumatic brain injuries. What do you think? What type of functional tasks? Driving a car. Perfect example. How complicated is it to, all right, walk me through the steps on how we're going to drive home in hopefully less than a half an hour. Step one, what's step one? We got to get in the car first. We got to open the car door. All right. Anybody, to do that, anybody ever open the car door directly into them? What do we have to do? So it's not even as easy as reach the handle and pull. It's reach the handle, pull, step back to get out of the way. Now step back in. Oh, you've got to let go of that outside lever. Oh, you forgot to do that. Now reach to the inside. Okay, now that we're here, go to sit down. Oh, well, you hit your head. Okay, we got to go back to it. Okay, eventually we get in the car. Eventually we're going to learn how to shut the door. Then what? Put the key in the ignition, about to be a dated reference. Or the push. How many cars have push? Mine still got a key. Anybody have the push with the push start, push igniter? Anybody have the thing where you crank the front of the car? And none of those, no Model Ts rolling around here. How complicated is it to drive? And we've barely turned on the car yet. Right. So breaking down the complexity of tasks. Now, even if we're not going to drive, how complicated of a task is it to be a passenger in the car for someone who has this amount of cognition trouble? Right. So it can be really, really tough. Anybody ever try to teach someone when they just don't get it? Kids are great for this. You say, no, just do this, right? Why? And they're just not understanding the words and how we're doing it, right? Yeah. And we have to teach the loved ones, the caregivers, the families to say, whoa, they can't process that information. Break it down one word at a time. Back up. reach, pull, right? So really telling that to our family, because the family's sitting there going, Larry, just get in the car. Why are you doing this, right? So it's a bunch of caregiver education as well. Treatment for gait training, progressing the speed, sometimes use of auditory cues like a metronome. So that can help, that discontinuous gait that I talked about where they're, well, if we use a metronome, okay, listen to the beats. Boom, boom, boom. Take a step every beat now. Boom, 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 right? So that can start helping that patient learn how to be a continuous pattern. We could also look at compensation techniques, use of assisted devices, ADs, is that abbreviations, walkers, canes, hemi walker. There's a million different kinds of walkers and canes out there. Eventually you'll learn them. Might also require braces, like an AFO. Anybody see what? Let's see if. There's the classic AFO. There's a million different kind of design changes to it, but that's it. Anybody ever see one of these insert into somebody's shoe? So this part fits right in their shoe and it just helps the foot. There's a condition called foot drop where the muscles here, anybody who's taken anatomy know which muscles these are that control the foot pulling it up? Anterior tib, tibialis anterior. Yep. So there's some problems where the anterior tib won't fire. It's a neuromuscular problem. All right, if that won't fire, if I can't pick up my foot like this, but you're asking the person to walk, what's the danger? We're going to trip. We're not going to step over things. Level ground, I might be okay, but those transitions, those little thresholds you have to step over in your door, we're going to trip over those. Rugs, like if we had a throw rug, we're going to trip over that. So that person is a high risk for fall. So we add an AFO to them. And this just keeps the foot in neutral. The brace is going to hold the foot up. So that's the compensation that person might need. That's cheap. Yeah. There's cheaper ones. I mean, we could look at this one, $40. Not quite as comfortable. Not quite as cool looking. And then for some people, I had a patient with really, really minor foot drop. And we got them, it basically looks like anybody ever sprained their ankle and needed a brace? It looks like just something you go to CVS. Actually, I told him to go to CVS to buy an ankle sprain brace because that's all he needed was just a little bit. So, I don't know. I don't know. Looks similar to that. Oh, this one's got a little loop to grab the shoelaces. That's pretty cool. All right, enough AFO talk. Let's look at gait impairments after. Oh, we're not doing that. Gait impairments after. Come on.
Really? Just your plan for movie night? Yeah, I got rid of our cable internet.
So we're punching your Wi-Fi.
A person with hemiplegia has a difficulty in walking.
All right, let's try to go back here. What assistive devices is this person over here using to ambulate? Using a cane, an AFO, okay? Now, what do you think he's using the cane for? Balance. And if we look at the cane, do you see it's got 4 prongs? It's called a quad cane. More stable than if it was a straight cane, a one prong. He's using the AFO for that exact problem we're talking about. Do you guys also see when he goes to walk, if we had what we would call a normalized gait pattern, we're gonna stay in line. Our legs are just gonna be in line. You can draw a line right behind me as to exactly where my right foot and my left foot are gonna be. Watch this foot and tell me if it's going straight through or if it's going somewhere else. That'll be the gait deviation we look at. Let's see. Swinging it out wide, right? So that's called a circumduction gait pattern. There we go. Got to get it out wide. So he's doing that for a few different reasons. It could be because of that foot drop and that brace just isn't doing its job, keeping the foot up. Most likely it's because of weakness, neuromuscular weakness. That is it. So anyway. Going to talk about 3 different conditions: a cerebral vascular accident, stroke. So the anatomy is decreased, the mechanism of injury or illness, decreased blood supply to the area, either due to hemorrhage or blockage. Our tissues need blood, right? With blood comes oxygen and other nutrients with it. It also clears metabolic wastes. So we need good blood flow to and from. We can block blood flow by filling up that artery with a blood clot. Now the blood can't go around that clot. Or we can cause a hole in that blood vessel, so anything distal to that hole won't be collecting blood. All the blood's leaking out, just like a garden hose, right? If I want the water to come out, I have to make sure there's no rocks in the garden hose, because that would block the blood flow. Or if there's a cut in the hose proximal to my nozzle head, the water's going out over there. They're not coming out here. That's the same way that the blood vessels work and could have an injury. Now, here's the crazy stuff. A brain injury, and once you learn your neuroanatomy, so when you're in your PTA class, you start doing brain stuff, you'll see the anatomy why, and you can ask your professor, yeah, but why is it? Say, who did you talk to? I said, Josh. Oh, that guy again. The brain injury will present physical symptoms contralateral. You guys know what that word means? Opposite side of the brain to the body. So if I have a right brain injury, stroke, or traumatic brain injury, my physical symptoms will happen in my left side of my body. It's pretty wacky, huh? So either ruptured blood vessel or a blocked artery. Most of the time, it's either from a blood clot or the gradual buildup of plaque buildup, causing the arteries to become more narrow. Most strokes happen with someone over the age of 65. Static impairments, once you have one, that's it. Once we resolve that problem, once we resolve the block or fix the bleed, it's done. It's not going to progress, but you are at risk of having another stroke down the road. Whether it's temporary or lifelong depends on the severity of the stroke and the luck of the patient. I've had plenty of patients I thought would get better that didn't, and I had plenty that I didn't think would get better that resolved almost all the symptoms. So there's such a wide range of who's going to get better, and I know I couldn't tell you who's going to get better and who doesn't. We just got to try hard and see what happens. Now, the treatments are going to really be a variety because of the variety of symptoms, right? We talked about the different lobes of the brain and how they can have different symptoms. So it really is, where does the area of the injury is going to dictate the impairments, and that would dictate the treatment too. Broadly speaking, mobility-wise, we're going to progress from sitting to standing and then relearning functional tasks like walking, cooking, getting in and out of the car. Spinal cord injury, next common one. The spinal cord injuries can be really complicated because I think most of the time we think of spinal cord injuries as complete. They're either you're good or you're bad. Either it's intact or it's not. But there are incomplete spinal cord injuries. A lot of times it happens either because of a stab wound or a gunshot wound where it only penetrates half of the spinal cord. But what is the mechanism of injury? Hyperflexion or hyperextension of the cervical spine is the common mechanism. Dislocation of a vertebrae, compression fractures, and then penetration injuries, stab wounds or bullet wounds are the other mechanisms to have these spinal cord injuries. Now, most spinal cord injuries occur in younger men. Average age is 38, and in my experience, that's old. In my experience, it happens to young men in their early 20s. 50%. Why young men, especially if they're in their 20s? Could be ego lifting. Yep. Absolutely. Yeah, I think if we just say feeling foolish, that's probably it. And it could be I've never went skateboard before, and let me try that half pipe out. Skiing, I'll give it a shot. Like, what is this what is this black triangle type shape? No, it's a diamond. All right, there's two of them here. Is that good? Like, let me try it out, right? So it is the adrenaline seeking activities and behaviors. 50% of spinal cord injuries are due to motor vehicle accidents, either car or motorcycle. Static, once you have it, once all of the problems are resolved, the impairments are the impairments. This spinal cord injury is not getting worse in 3 years, so it's done. But it will have lifelong. The goal of the rehab team here is assist the patient in performance of ADLs, figuring out which assisted devices are best, prevent future complications like skin breakdown, pneumonia, urinary tract infections, different musculoskeletal issues. There's a whole host of different problems that can happen with someone after a spinal cord injury. But really our job is to say, okay, the way you knew how to move before is no longer the way you're going to move. But we'll get you back driving. We just have to figure out how that's going to happen. And we've got to modify the car. We've got hand controls. We've got to learn how to break down your wheelchair and fling it in the back seat. Like, we can do all that stuff, but man, we're going to have to really learn how to do all of this stuff. So now a special thing to remember about spinal cord injury. There's something called autonomic dysreflexia. Serious complication triggered by some sort of negative sensory stimulus. Call that a noxious stimulus, a painful or danger. Causes a massive reflex response that can't be controlled by the brain. The stimulus could be something as a distended bladder, but the patient doesn't have the sensory ability to say, I need to go pee. So they have a full bladder, and that's that noxious stimulus. That noxious stimulus is below the level of injury. That's because we can't feel it. The sympathetic response causes severe vasoconstriction. What's that mean? You can break down that word for me. Constriction, so narrowing, constriction of the blood vessels, which causes a sudden increase in blood pressure, a drop in heart rate, excessive sweating that occurs above the level of the spinal injury. That to me is the most fascinating thing. So if I had a spinal cord injury from here down, if I had this, you would see me sweating a lot here up and not sweating at all there down. It's pretty wild. The big problem with this, because of the drastic increase in blood pressure and the drop in heart rate, high risk for stroke right now. That blood pressure is so high, we could be causing a stroke or heart failure right now. So it has to be resolved quickly. One, remove the noxious stimulus. Most of the time, it's a catheter problem. Catheters are inserted into the person so they can, that catheter is going to pull out all the urine. So usually it's a kinked catheter line or it's caught somewhere that we don't know. That's the most common one. And then we don't, but they are given medication to lower their blood pressure. So here's a little picture of what happens there. I like that picture, so I threw it in there. All right, last thing for us, Guillain-Barré syndrome. It is a peripheral nervous problem now. Unknown cause. What's that unknown cause medically mean? Idiopathic. It's likely an autoimmune disorder triggered by some sort of infection. This autoimmune reaction causes demyelination and axon destruction that will repair itself as long as the cell body remains alive. So when you guys are taking anatomy, here are those things to look at. First of all, what is myelin? What is an axon? And what is a cell body? Right. So when you start learning your anatomy, those are the structures you need to identify. Roughly 1 in 100,000 people each year will have Guillain-Barré. How many people are in Rhode Island, roughly? Right around 1 million. How many people in Rhode Island will have Guillain-Barré each year? 10. In 1 year, I had 4 people with Guillain-Barré that I helped. And I was never a neuro PT. There are some PTs out there that specialize in neuro. I think in week 1, we look at chapters and academies. There's a neuro academy. I would not part of what I've ever done. Just happened to be lucky and got 4 out of the 10 people in Rhode Island that year with Guillain-Barré all were with me. Now, here's the crazy thing about this condition. Most cases resolve in a few weeks to maybe a year or 2. Some might have minor residual impairments. I had one guy, he was in his early 50s. His big goal was to get back to skiing. He got back to skiing, and I haven't talked to him in years. But last time I talked to him, he goes, "No, I'm perfectly fine, except the last run of the day, I can feel my legs getting weak again, and I know, like, okay, it's time to stop." So he, similar to my friend who had the stroke, where the fatigue kicks on symptoms, that's where he's at. So the rehab progressed at the rate of the nervous system recovery. Caution to limit overexertion. Initially, the goals. So what these people look like, it looks like they're having a stroke. It looks like they have ALS. Like there is a rapid decline in function. Usually starts with tingling in both legs, and then it great trouble walking, potentially great trouble breathing and speaking, but that will recover. So we might need to prevent a DVT. You guys know what a DVT is? Deep vein thrombosis. That's a blood clot in the leg. So though blood clots happen because of immobility and other reasons, but that's a big thing that we can provide to them. So we're going to prevent that. We're going to teach them bed mobility, transfers. How do we get out of bed? Gait, walking, and regaining optimal level of function. So pretty wacky condition. The good news is they get better. And we just have to be their cheerleader and encouraging them along the way. All right, so those are some abbreviations that I think were new for today. Make sure we know them. CVA, cerebrovascular accident. TBI, traumatic brain injury. SCI, spinal cord injury. AD, assisted device. Orthotics are the best because the abbreviations are just the joints that it crosses, and the last word is orthosis. So an ankle foot orthosis is an AFO. What about if it was a KAFO? Now it is knee, ankle, and foot. What about an HKAFO? Hip, knee, ankle, foot. SEO, shoulder, elbow orthotic. SO, just shoulder. Anybody wear a sling? You wore an SO. Congratulations, you didn't even know it. So anyway, that's the ankle foot orthosis. And then DVT is deep vein thrombosis. All right, any questions? Don't back up yet. I got something for you. You're going to hate it. Next week, we have our first exam covering the intro PowerPoint week 1, musculoskeletal, PTs versus PTAs, and then neuromuscular, 4 weeks of information. You have your learning objectives you get to use as your study guide, okay? Who has not taken an exam with using Respondus lockdown browser? Okay, that's okay. We're going to try it out. So I have a homework for you. The homework is under exams. Let's do student view. All right, under exams, practice quiz requires Respondus lockdown browser and webcam. Here's your password for this. Cut and paste it. Good. Begin. It requires the password. And then what should happen, I'm not sure why it didn't, I'll have to look at this, is it should kick on your webcam, make sure that and it tracks your eyes so you're not cheating. That's all it is. It also should, maybe because I'm in student view and not your view, but it should also not allow me to open up browsers, again, to prevent cheating. So this is 10 questions. I gave you 25 minutes to do it, more time than what you'll have on the exam. I think I gave you 5 attempts at it. Let's see. Yeah, 5 attempts at it. So the goal of it is to make sure you have the technology piece work, because just the reason why we moved next door is because I didn't want testing anxiety of having to find your classroom. Now I'm late. Where is it? And now I have to take a test. That's a terrible feeling, right? So take this practice quiz before next week to make sure your computer works. That's all it is. I give you 5 attempts so you can get all the right answers. But guess what? It's 10 questions I pulled from the study, from the learning objectives. So it's a little way you get to study. Hey, how am I doing on this variety of topics? What am I missing? I didn't realize that abbreviations were going to be up for grabs, right? So it's just a little study tip. Take it 5 times until you get 100%, and then you got your homework done. Okay? All right. Any questions? All right. Oh. Maybe you guys have the questions I was about to answer. Next week, because we're going to use lockdown browser and I trust your academic integrity, if I see signs of cheating, we will never be able to do this again. How many people it's a haul to get here? So here's my gift. You can take it. When did I shut this off for a second so you don't see the exam? Let me see. So my gift to you is you can take it anywhere of your choosing. You just need a computer that works, okay? My trust in you is that you're not going to cheat. The other gift is I opened it up from 3:30 p.m. to 9 p.m. So you have a little bit extra time to take it. It is timed. You have 2 hours to complete it. It's 50 questions long and you have 2 hours to complete it. So I think it's a more than generous, time. There are some people with exceptions, learning, exceptions, and don't worry if you have them, I took care of them. If you don't know what I'm talking about, that's okay. Don't worry about it. If you think you want some, come and talk to me. But my gift is a bigger exam window, so maybe it can fit in your life a little easier. You also can take it anywhere you want. The gift you given me in return is I trust your academic integrity. We're using the other technology. I've taken many tests. There's always a way to cheat, right? If you really want to, there's always a way to cheat. I'm going to trust you not to. Okay? All right. Do not have to come to class next week. Take the test and once you're done, once you press submit, we're all done for the week. Yep. Okay.
Do we have to be staring all the time? Webcam? For something when I was trying to see if they were like, you're doing something, so what you're doing, and I was trying to move it.
Yeah.
Like, it's
Yeah, I hope I put the settings loose enough where you're not going to be yelled at if you take a sip of water. But it will also record you and I'll be able to tell if you're cheating or not because it's recording your eyes. So, I'm not worried about that. What it does on my end is it flags like, high movement risk. And then it says, okay, watch the video. And it's always nothing. So, all right. Any other questions? All right. So you have a homework to test your system and it's a little study thing. Don't hurt yourselves with it. It's not, take it as many times until you get the right answer. And then next week is the exam. Reach out to me with the email if you need anything. Okay. All right. See you guys.